The topic that we have to start with now is the fracture in the neck of the femur. Now, before even coming with the classification or talking about the classification or the categorization of the fracture neck of femur, it is important to discuss about the possible complications. So, the first thing that we are going to discuss is the complication in the fracture neck of femur. You know, the two most important complications associated with this are avascular necrosis in the head of femur, and the second one is the non-union. We have already discussed about the avascular necrosis, how avascular necrosis in the head of the femur is the result of the fracture neck of femur. But now is the time to discuss about non-union, means why non-union is so common in case of fractures in the neck of femur. So what are the reasons for the non-union in fracture neck of femur? One of the reason is precarious vascularity. Now, important point is that the vascular arrangement in the neck of femur and in the proximal part, that is head of the femur, is precarious. That means it is insufficient or ineffective as far as the vascular supply to the head is concerned. The amount of the vascular supply that should have been there in the head as well as in the neck region, it is not provided. So that is one reason, precarious vascularity. Second reason is that these fractures are intracapsular, and inside the capsule there is a presence of enzyme. The name of the enzyme is hyaluronidase, and the action of this enzyme is to break the clot, that it breaks the hematoma or clot. So that is another reason. You know, the first stage of fracture healing is the formation or condensation of the blood. It is the hematoma formation. Over to that hematoma, there will be a inflammatory response which will initiate, or it is acting as a bed for the collection of all ingredients which are required for the union at the site of the fracture. If there is a presence of such enzyme, it is interfering right at the first stage of fracture healing, and that first stage of fracture healing is the hematoma formation. There will be no hematoma in the intracapsular fracture because of this enzyme, thereby it is impeding the union. And the third reason is that there is no cambium layer around neck of femur. You know, in the periosteum, the inner cambium layer, outer is the fibrous layer. If there is absence of the cambium layer, and we know that cambium layer is responsible for the formation of the bone, thereby it is a disadvantage again on the part of the neck of the femur where there is no cambium layer, thereby responsible for increasing the chances of non-union at the site fracture neck of femur. So having discussed about these two possible complications, one is avascular necrosis and the second one is the non-union, now we can easily understand the classifications associated with the fracture neck of femur. Now, first of the classification is anatomical. Based on this diagrammatic representation, we can easily understand how this anatomical classification will work. Like, if this is neck of femur, there are three different types of the fracture which can happen in the fracture neck or in the around the neck region. One is subcapital. Capit is the word which is used for the head. So just below the level of the head will be subcapital. Then the second one is transcervical. That means through the cervical region or through the neck region is transcervical. And the third one is basicervical. Cervical region is the name for the neck, and at the base of the neck will be called as basicervical. But what is the importance, what is the significance of this classification? That proximal the fracture, poorer the prognosis. That is the significance. If there is a proximal fracture, it will be having poorer prognosis. That means out of subcapital, transcervical and basicervical, the worst prognostic outcome is that of subcapital fracture. That is anatomical classification. After this anatomical classification, the another set of classification for the fracture neck of femur is Powell classification. And what is Powell classification? Again, on the basis of the diagrammatic representation, we can understand this. That if this is the horizontal plane and we are comparing the two fracture lines according to these horizontal planes, so the two fracture lines are, So another classification is the Powell's classification. Like these are the two fracture lines which are being compared with the horizontal plane. If this is fracture line A and this is fracture line B, then out of these, fracture line A is having a greater angle with the horizontal compared to fracture line B. And what is the significance of this Powell's classification? That greater the angle between the fracture line and horizontal, if there is a greater angle between fracture and horizontal, poorer the prognosis. Poorer will be the prognosis. So when you go and means if you study this Powell's classification from the book, it will be written as 30, 50 and 70 degree. It is just the reference values that greater the angle. That means 70 degree angle will be having poorer prognosis, higher chances of non-union as well as avascular necrosis head of the femur. So that is about the Powell's classification. Now the third classification after anatomical as well as the Powell's classification, the third one is based upon the trabecular pattern of the femur, and this is known as Garden classification. The third one is the Garden's classification. First of all, try to understand what is there in the Garden classification. You know, this is the normal acetabulum, head of the femur and neck of the femur. And the medial surface, this surface, the medial part of the femur is the principal weight bearing surface. So it will be having greater strength compared to the lateral as far as mineralization of the bone is concerned. And that mineralized pattern will be appearing like a trabeculae along the weight bearing axis. So there will be a trabeculae of the acetabulum, there will be a trabeculae which is aligned to this in the head of the femur, and there will be a trabecular pattern in the neck of femur. So all of them are going to be aligned along the weight bearing axis, that is the trabecular pattern. But what happens in the different types of the fractures in Garden classification, this is what we are about to study. So here what we have discussed, that there are three trabeculae. One is that of the acetabulum, the second one which is in alignment with the head of the femur, with that of the head of the femur, and the third one is that of the neck of femur. And all the three has to be smooth, has to have a smooth alignment along the weight bearing axis or along the weight bearing forces. That is about the Garden classification. So what are the different types of fractures according to the Garden classification? According to the Garden's classification, the fracture lines are further divided into, means the fracture is divided into 4 different types. The type 1 is incomplete fracture, and this incomplete fracture is also known as valgus impaction fracture. The type 2 is known as complete fracture, but there is no displacement. That is type 2. Type 3 is complete fracture with partial or incomplete displacement. And type 4 is going to be a complete fracture with complete displacement. And how these different types of the fracture lines will be having an impact on the trabecular arrangement, this is what we are about to study. You see, what will happen in case of type 1, that if this is the acetabulum and this is head of the femur, after getting an incomplete fracture, there will be a valgus kind of the impaction with the fracture neck of femur, and this is the greater trochanter, lesser trochanter. So the trabecular alignment of the three more or less to some extent remains the same, except for some angulation at the level of the head and neck interface. That is for type 1. There will be some break at this head and neck interface in case of type 1. But what will happen in type 2? If this is the head of the femur, neck of femur, this is greater trochanter and lesser trochanter. Because the fracture line, although it is complete, but there is no displacement at all, so all the three trabecular pattern will be having a smooth alignment. There will be a smooth alignment in all the three according to the type 2. The trabecular pattern of all the three will be having a smoother kind of the alignment. Now what will happen in type 3? In type 3, if this is the head of the femur and there is incomplete displacement, so some of the contact is maintained in between the fractured neck as well as head, and this is rest of the femur, and this is the acetabulum. Because of this compact or because of this attachment, it will result in the varus position of the head of the femur. It will be rotated inwards. So as a result of which, the trabecular alignment of the acetabulum will be disaligned with that of the head of the femur, and it will be disaligned with the neck of femur. So there will be no alignment at all in type 3. So what is very clearly evident in the type 3 fractures, that there is no alignment in between the fracture lines at all. That is type 3. And what will happen in case of type 4, that if this is the acetabulum and this is the head of the femur, and after a complete displacement, what will happen is that the trabecular alignment of the acetabulum will be smooth with that of the head of the femur, because the head of the femur will be rotated back to its normal position, but the trabecular alignment in between the neck and the head will be disturbed. So that the disturbance will be there in case of head and neck. There will be discontinuity in the framework of the head and neck. So this is how diagrammatically it could be very easily explained, that how the trabecular patterns are responsible for its final outcomes based upon the Garden classification. So 3 classification we have discussed: anatomical, Powell's and Garden classification, and we have found that it is the Garden classification on the basis of which the long questions or important difficult questions could be framed based on both, one, the theoretical aspect, and the second one is the diagrammatic questions like this. Okay. Now, having discussed this about the classifications of the fracture in and around the neck of femur, now is the time to discuss the management, the treatment protocol for the fracture in the neck of femur. The 2 categories of the management in the fracture neck of femur can be very easily explained from these X-rays itself. One, after the fracture neck, you are trying to preserve the fracture, or you are trying to preserve the normal bone. That is achieved by osteosynthesis. That means you are fixing the fractures. And another way of the management is you just replace that fractured head as well as the neck region, and you are fitting an artificial implant, that means a prosthesis inside, and this is known as hemiarthroplasty. Half of the hip you are replacing. So hemiarthroplasty. These are the 2 methods of the management. So how this treatment will be influenced? So we'll be talking about the management, and in the management, if the question is based upon the question, like if in a question only age is given, only age is mentioned in the question, then what you have to go for, that for less than 60 years of age, you have to go for osteosynthesis, and for more than 60 years of age, you have to go for hemiarthroplasty. Although practically the things are different, there are multiple variations to this management criteria. Practically, it is not only the age that is taken into consideration, rather there are multiple other things, like which one will be having greater chances of going into non-union, which one is found to be more displaced, greater chances of avascularity. So based on that, the management is decided. Second is that if in question age plus associated comorbidities are given. For example, the patient is also suffering from diabetes mellitus, the patient is also suffering from recurrent chest infection, the patient is having subdecubitus ulcers, the patient is suffering from the superficial or deep venous thrombosis. Now in all these conditions, what will happen? The ambulation is required, and you have to make the patient walk immediately after the surgery. That is only a possibility when you fix it, when you replace the hip joint by putting the artificial implant in the form of internal prosthesis. Then only weight bearing immediately after surgery is a possibility. So if in a question age and associated comorbidities are given, then you have to go for hemiarthroplasty. Now hemiarthroplasty implants are of 2 types. There are 2 different types of the implants. These are a unipolar and a bipolar. Unipolar implant and bipolar implant. Now, what do you mean by the term unipolar? Unipolar will be having one head and bipolar is going to have two heads, means head within a head. So, over there is going to be a cup, under this there is going to be a head. So, two bearing surfaces are there in the bipolar implant. Unipolar implant is further divided into Thomson prosthesis and Austin-Moore prosthesis. In case of Thomson prosthesis, there will be no eye in collar, while for Austin-Moore prosthesis, there will be a presence of eye in collar. Now, having discussed this kind of differentiation, now it is very easy for you to identify what is the name of the implant which is provided over here. Now, if you look at this implant in particular and this implant, one thing which is common in both of them, that there is a single head in both of them. But in this case, there is one outer shell and inside there is another head. So, this implant is a bipolar implant. This is a bipolar prosthesis. What are the advantages of bipolar over unipolar? And practically the bipolar will be converted into unipolar after some duration of time. All these things are never going to be asked in your examination. What is likely to be expected is the identification of the implant on the given picture. So that is the criteria that you need to learn. So what are bipolar implants? Having two head, a head within a head, that is bipolar implant. Now come to the unipolar implant. Now in any unipolar implant, this region is the head, this region is the neck, and this one is the stem of the implant. Now in the neck region, as you can see, there is no eye, there is no hole which is present in the neck region around this prosthesis. So there is no eye in the neck. But on the other hand, this is the head, this is neck, and this is the stem for this prosthesis. And here what you can find very easily, that there is a presence of an eye in the neck. So this prosthesis, the first one that you have that the prosthesis which is having no hole, no fenestration or no eye in the collar, it will be called as Thomson prosthesis, and the prosthesis that has an eye in the collar will be called as Austin-Moore prosthesis. Another thing that you can also ask is that in the stem of Thomson prosthesis there are no fenestrations, while in case of a stem of the Austin-Moore prosthesis there are presence of the fenestrations. So this can also be considered as a feature for the identification of the implant, but ideally it should not be considered as a feature for its identification, because non-fenestrated Austin-Moore prostheses are also available. Based upon whether you are going to use the Austin-Moore or not, whether you are going to use it in more elderly compared to less elderly, whether there will be a use of assisted cementing procedures along with this hemiarthroplasty or not. On that basis, Austin-Moore are further categorized into fenestrated and non-fenestrated. But the point of distinction over here is the presence of eye. Eye is something that you need to recognize. Okay, that is all about your identification criteria for these fractures.